Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much for having me. It is fun to be here on this side of the camera after seeing this as a fellow. I am going to attempt to tell you all about event-driven HIV prevention and event-driven STI prevention for people assigned female sex at birth. These are big topics, but my goal today is to make sure that you are up to date on the latest data and kind of the edge of the debate and question. So no disclosures or conflicts of interest. Disclaimer from the folks here at MWATC. And data considerations, I'm not touching on topics surrounding the impact of racism on health outcomes, but always important to consider this when hearing about data. All right, so I'm going to start by diving into event-driven PrEP. So I'm going to start by making sure we're all on the same page with the one and only event-driven PrEP trial. There is only one placebo-controlled RCT on event-driven PrEP, also known as 211 PrEP. And this study was done in the early days of PrEP before we knew that daily oral PrEP was effective. So that's why we don't have more placebo-controlled trials since then. And this trial was primarily conducted in France, only enrolled cisgender men who have sex with men, and it showed that it was highly efficacious with only 2 breakthrough infections among those randomized to take the on-demand PrEP. And similar to what we saw in daily PrEP trials, those breakthrough cases were in the setting of non-use, so they had low drug levels. One important criticism that came out of this trial at the time was that participants in this trial had a median of 4 pills per week. So much of the discussion at the time was, is this truly measuring the impact of event-driven PrEP, or are we actually just measuring imperfect adherence to PrEP? And I specifically call this out because there have been a number of studies that have supported the idea that among those people who are born male sex at birth, 4 doses a week is enough to be efficacious and to prevent HIV, but the standards are different for people assigned female sex at birth. So what do we know about people assigned female sex at birth when it comes to intermittent PrEP? And here I say intermittent PrEP, not on-demand PrEP, because in ADAPT trial, they randomized cisgender women in South Africa to a pre-post PrEP, where you took a dose 2 hours before and 2 hours after, very restrictive, hard to get the timing right on that, or to daily PrEP, or to weekly dose of PrEP. And this trial was designed to really understand the ideal dosage for PrEP for HIV prevention. This study showed that there were 2 breakthrough cases among those randomized to the weekly group and 2 among those randomized to pre-post dosing. So this really limited enthusiasm and a lot of concern that maybe intermittent dosing of PrEP just won't work for cisgender women. And I'll also call out that they calculated coverage of events. So was the recent Sex Act covered with appropriate dosing? Another way we can think about adherence that's really more patient-centered. And they saw decreased coverage among those who were randomized to pre-post compared to daily. So there's this other element of, well, if maybe it's too confusing or people can't time it, so that maybe this isn't a good option for people. And a lot of this concern that maybe it wouldn't work for cisgender people at all was really based in the pharmacokinetics and looking at differences in drug levels in different parts of the body. So in this PK study, looking at 47 cisgender women who are all given TDF PrEP, they looked at time to protective levels at different compartments. And here you can see the rectal tissue, looking at M-tricytidine bars on the left by days of the week, and the middle selection is tenofovir drug levels over the course of the week, and then a composite on the far right. And you can see that there is one column that is very dramatically low compared to the others, and that is the vaginal drug levels for tenofovir are much, much lower. And so this really led to the idea that The standards need to be different for people who are having vaginal or front sex because it's just really hard to get those drug levels. But we all know, and I put in the box here, that daily PrEP works for people having vaginal or front sex. So how do we reconcile this? There has been a really interesting modeling study that just came out last year, Zhang et al., where they did some really gorgeous modeling of looking at PK data across multiple studies and really looking at if we predict perfect adherence. So looking first on the far left in that light blue, if people are just taking one dose a week, do they even come close to those protective levels? And then as you increase the doses per week, how are we doing? And even with 7 perfect daily doses, you never reach protective levels in vaginal tissue. This doesn't totally make sense with what we know, because we know that PrEP works for people having vaginal sex. And so the other thing that they thoughtfully modeled was, what about drug levels within PBMCs, or those peripheral lymphocytes, where the infection takes place, where the virus is interacting with those cells and integrating. And here you can see a model much more similar to what is accepted for people who are assigned male sex at birth, where we see if you have at least 4 doses a week, you are getting up to that threshold of protective drug levels in the PBMCs. This is very thought-provoking, and this is very interesting. This is a modeling study, though. So can we make clinical decisions based on a modeling study? Around the same time, Jeannie Marazzo and colleagues gathered data from 11 sentinel studies of PrEP among cisgender women. And these studies took place in 6 different countries from 2012 to 2020. And here they were able to pool the 3,000 people who contributed adherence data. So not all of those 11 studies had adherence data, but among those where they did have adherence data, they were able to pool this large cohort of almost 3,000 people and look at what does it mean to have, kind of looking at trends in dosage here. On the top line, you can see those 7 perfect daily doses a week. And then below that is the 4 to 6 pills per week. And here they saw no difference in 7 perfect daily doses a week compared to those who are taking 4 to 6 pills per week. So this brings me to the very controversial question on this side: do vaginas demand perfection? And I would say not when it comes to PrEP. And that I think maybe that people who are having vaginal or front sex can be just as imperfect as we've been allowing cisgender men to be. And so if we know that imperfect adherence is protective for cisgender men, and we know that event-driven PrEP works for cisgender men, and now we're seeing data both in modeling and pooled data from across multiple trials that imperfect adherence is suggested to be protective for cisgender women, might event-driven PrEP work for cisgender women? Do we really need to hold out for the idea of a placebo-controlled trial, which we will not likely see in an era where we know that PrEP works? Or can we move forward with more clinical investigations, start offering this as an option in real-world settings? Okay, there's so much more I could have said about that, but I just am going to give you that little teaser, and so we can leave some room for questions at the end. I'm going to move on to talking about STI prevention and DoxyPEP. So I'm primarily going to focus on the trial that I was a program director for, the DPEP Kenya trial, and that's not just out of self-promotion. It is unfortunately because this is the only trial to date with data on people who are assigned female sex at birth taking DoxyPEP. So we know that STIs are on the rise, and we know that this is happening regardless of sex or gender around the world. And we're especially seeing this among people who are on ART, people who are on PrEP, or people who might benefit from PrEP. We also know that the sequelae of bacterial infections, specifically STIs, can be much more severe in the uterus, with long-standing chronic pelvic pain, infertility, or poor birth outcomes. There have been several trials to date that show DoxyPEP is effective at reducing incident bacterial STIs among people assigned male sex at birth. These were done in France and the United States. They saw a 60 to 70% reduction in STIs, especially when looking among syphilis and chlamydia, seeing nearly 80% reduction, where you have a little bit more hit or miss with the gonorrhea, depending on local resistance patterns. Additionally, there's been some newer data in the last year that have been published that show doxycycline drug levels are much more variable, but high in vaginal secretions. So here, going back to, again, lots of pharmacokinetics, what's happening with drug levels at different compartments. And I think this is a theme that goes across both HIV prevention and STI prevention, but notably different because we're not talking about a virus here, we're talking about bacteria. Okay, so let's talk about the DPEP Kenya trial so you're up to date on what we found in that study. This was an open label, one-to-one randomized trial where the intervention is 200 milligrams of doxycycline within 72 hours of sex. And we compared that with folks who are randomized to just getting the quarterly STI testing and treatment alone. We randomized 449 non-pregnant cisgender women aged 18 to 30 who are all taking HIV PrEP and all living in Kisumu, Kenya. And this took place during 2020 to 2022. We followed participants for a year and did quarterly follow-up STI testing as well as multiple surveys on behavior. So jumping straight to our results here, we had a well-balanced cohort with 224 randomized to taking DoxyPEP. Average age was 24. Most people had been on PrEP for some time prior to enrolling in this study, around 7 months, and high baseline rates of STIs comparable to what we're seeing in MSM cohorts in high-income countries with 13% among the DPEP group and 15% among the standard of care group, just chlamydia alone. Notably, there's very low rates of syphilis, and this is consistent with other studies in the area. Participants had excellent follow-up during this trial, with 97% of the follow-up visits completed. We also sent them weekly text message surveys to ask them about their sexual behavior and pill taking in the prior week, and 82% of those surveys were completed. During the study, we had 44 pregnancies in the DPEP arm alone. We also had 36 in the standard of care group. And among those 44 participants, because we stopped doxycycline PrEP during pregnancy, accounted for 10% follow-up time. And then there are additional 5% holds due to side effects or other concerns. Okay, so looking at some of our behavioral data and PrEP use data. So we saw that in those SMS or text message surveys, most people reported that they were taking their pills, but I want to call out that some people were reporting that they didn't have any sex that week. So this is a difference from the DoxyPEP studies among MSM, where there was, I think, a little bit more sexual activity among those participants. So in 28% of the weeks, our participants were saying, I didn't actually have any sex this week. Around half of our participants had multiple partners at any given follow-up visit. So not completely different from the DoxyPEP study. This isn't just a study of monogamy or perceived monogamy, but I think a notable difference from the trials among cisgender men. We did have 13% of our participants tell us that they stopped taking PrEP during the study, and this was mostly due to a change in relationship. We had no incident HIV cases over the course of the study. So the final results. So we had a high incident rate with 27 per 100 person year of incident STIs. This is a very high rate for all comers of people who are taking PrEP. We saw no difference in our primary endpoint of incident STIs. We had 50 incident STIs among those assigned to doxycycline PEP and 59 among those assigned to standard of care. When looking at chlamydia alone, we again saw no statistical significance and again, no difference in gonorrhea. Accounting for that censored time during pregnancy, we removed people from the analysis once they became pregnant, both in the DPEP arm and in the standard of care group. And this, again, showed the same result, no significant difference in our incident STIs. We accounted for subgroup analyses looking at age, hormonal contraceptive, transactional sex, among those who knew they had an STI at baseline. And again, we saw similar results with no efficacy. A few secondary outcomes I wanted to point out. We had no adverse reactions related to doxycycline. Not a surprise, doxycycline is a well-known and safe drug. We did, however, have 4 participants report social harms related to using DoxyPEP in this study. As I mentioned, no incident HIV. And I will also point out that we had 100% of the gonorrhea isolates were resistant to tetracycline. This was molecular testing. But I think even with excellent coverage of sex acts, I wouldn't expect to see much benefit in preventing gonorrhea when 100% of the gonorrhea samples were resistant. We also tested chlamydia samples for a theoretical molecular marker of resistance, and we did not find any. Okay, so why? Why didn't it work in our study when it worked among cisgender men? And I think this is a very similar result to what I was just alluding to with the PrEP studies, where low usage is likely contributing to poor efficacy. So we had a random subset of 50 participants who were assigned to DoxyPEP, and we took hair samples from them every 3 months. And those hair samples were equivalent to about a month of drug use. And so we were able to see, did you use doxycycline in that last month over multiple time points? And looking at our 50 participants, about 56% of them had taken doxycycline at least one time point. But when looking at all of our doxycycline hair, or all of the hair samples and looking at doxycycline levels, it was only about a third of the time that doxycycline was actually there. And so this likely means that there wasn't enough doxycycline use to measure efficacy results in this trial. I will note that there was some doxycycline detected at enrollment and in our standard of care group, just kind of demonstrating exposure to doxycycline in the community. So final conclusions around DoxyPEP for cisgender women. So our findings emphasize that we need STI prevention options for women, and I'll expand that to say for people assigned female sex at birth regardless of gender, that are effective and acceptable. And that adherence to preventive medicines needs to be better understood and supported for biomedical preventions to be effective. It might work in a trial, but if it doesn't work in people's lives, then it's not going to be very effective. And that these differences were likely due to low use in our study, and that we need more trials. We do need a definitive efficacy study, and I'm working with the Adolescent Trials Network, and we'll be launching a large 10-site study around the United States later this year to hopefully be able to answer this question, and we'll be enrolling across an age spectrum down to age 13. And we're hoping to recruit a large transmasculine population as well to answer this across people assigned female sex at birth, regardless of gender. So when talking about the DPEP Kenya study, I have to acknowledge the amazing, amazing team in Kisumu that made this happen, as well as many colleagues at University of Washington and colleagues in San Francisco. And that is it.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.